Okay, howdy class. Howdy. Today we have the honor of welcoming Dr. Peña-Purcell, PhD, MCHES, Master Certified Health Education Specialist. Dr. Peña-Purcell is currently the Associate Professor and Health Specialist with Texas AgriLife Extension Service here at Texas A&M University, as well as working with Texas A&M Health Science Center School of Rural Public Health as an adjunct assistant professor. She received her Bachelor of Science at University of North Texas with a political science degree, her Master of Science at the University of Texas at El Paso in Worksite Health Promotion. And lastly, she received her PhD in Health Studies from Texas Lumers University. She has held many positions as an exercise instructor to provide assessments, health enhancements, evaluations, and instruct exercise classes to promote healthy lifestyles. Dr. Peña-Purcell has received numerous awards and scholarships for her research and studies and has written several articles including Si Yo Puedo Controlar Mi Diabetes, Diabetes Self-Management Education Program for Hispanic and Latinos, and a worksite wellness planning guide and toolkit named Working Well, and authored many more diabetes-related articles. Her research interests include cultural competency, minority health disparities among Hispanics and Latinos, cancer prevention, health promotion, and diabetes health management education. Now please join me in welcoming Dr. Peña-Purcell as she presents Thinking Big to Reach Minorities with Diabetes, Research to Real-World Solutions.
Well, good morning. Good morning. I'm honored to have received this invitation to talk to the grad students here at Food and Nutrition. What I know of the work that you do a lot of clinical work. Some of you may be involved in nutrition and community-based programming. So there is a diversity of interest here. And of course, diabetes is a metabolic disorder, so it is very connected with nutrition. So I could see that this program has some interest for you all. I wanted to just first preface this by saying that this talk has a little bit of, I believe, something for everybody. Being that y'all are grad students, you probably are been exposed to a lot of theory here to understand the science behind the practice. And so I will give that perspective as well. But one of the things that I hope will illuminate this talk for you guys is just to see how we take what we know works theoretically and put it into the real world to find some solutions. Specifically, I'm going to be addressing also how we bring real-world applications and evidence-based practices or programs that can address disparities in diabetes care for minority populations. So I'm going to kick this off by kind of having a little quote to frame your thinking. I was using this quote by Donald Trump because it summarized what I am trying to capture in today's talk. So I'm going to I know you could read it, but I'm going to read it here. And it says, I like thinking big. If you're going to think anything, you might as well think big. And we know that diabetes among minority groups, specifically Hispanic Latinos and African Americans, is a pressing problem, public health problem. So how do we address this big problem? And the best way I could sum it up is to think big, to think that there are solutions, and the solutions that you can identify come from thinking big also. And big is, how do you engage communities? How do you engage the community members? How do you engage community partners and organizations to address this big problem? So rather than thinking that the problem is too big and that you're too small to address this problem, we all have the capabilities to address big problems by thinking outside the box and by thinking big. And I think that that's kind of been my approach in developing this programs that I will discuss today. Now, I was asked to talk about Selfregulation on the lot. We need these. We'll call it Selfregulation for short. And I'm going to talk about those, but since I developed that 4 years ago and have tested it, I have since translated that for African Americans. So you're going to see an evolution, so to speak, of the development of one curriculum to address one minority population that led to the translation of that curriculum for another minority group, which were African Americans. So you'll get to see how this big vision is addressing bigger communities that we can reach. So enough talking about big. Let's just look at what we want to accomplish today. And basically my goals today for this talk are to explain disparities in diabetes health, just to sort of frame and give you a context of the problem. I don't want to spend too much time on heavy data, but I have to kind of just set the foundation for why we do what we do. I'm a community health educator / public health educator. And so the work that I do is driven by need. The need is defined by, is there a real problem? Do we see the problem in statistics? Well, yes, we do, and we'll talk a little bit about that. And then I secondly want to talk about evidence-based approaches to improve diabetes self-care management. We just don't address problems with, oh, I think this will work. Your effort and time and energy is better spent if you could find out what does science speak to, how do you improve people's self-care behaviors. So we're going to talk a little bit about looking at what are evidence-based approaches to address the big problem. And then we're going to describe the two curriculum, Wisdom, Power, Control, and Sigue Puedo. And then we're going to discuss strategies to mobilize community support to build capacity. It's a little cut off, but that is pretty much the thing. It's a tall order today, but I think we can get it accomplished today. I am very, very flexible about how I present. I don't want to feel like I'm coming up here and necessarily pontificating. So if you have a burning question and feel that it's going to be forgotten, just raise your hand and I'll answer your questions. I move around. I have a preacher approach of presenting. I like to just move and just get in here. So I hope that you're comfortable with that. I don't want to be behind the podium. I want to be with you guys. So that's my kind of comfort zone, to be out there and be with you guys. Okay. So let's get the big picture, diabetes in Texas. So I'm going to set the stage for you all in understanding the prevalence of the problem here. So statewide, 1.8 billion Texans have diabetes. That's across ethnicities. It's a large number of folks that are affected with diabetes in the state. When we look at the distribution of our racial ethnic groups in the state, we know that whites make up the large proportion of our state's population, which is 46%. And then it's followed by Hispanics, and then it's followed by African Americans, which is 12%, and then 4% is other, Native American, Asian. What we're really focusing here is now we know that Hispanic Latinos is a growing population and is going to continue to grow. So when we look at the problem of diabetes with Hispanic Latinos, and we say that it's higher than whites, and we know that they make up a large majority of our state population, then we can see that there is a problem. However, when we look at African Americans, which only makes a small portion of that pie, we're thinking, well, there's not a lot of African Americans in the state, so there shouldn't be a problem. But what we do know is that even for the small number of African Americans that there are, their rates of diabetes are significantly higher than the rates of whites if you tease out the different groups. And so we can see that they're even more impacted by diabetes. And I just want to say that when we talk about diabetes, we're talking about type 2 diabetes, which make up 90%, 95% of the cases of diabetes. It's lifestyle related, as we know. So when we look at African Americans, their rate of diabetes is 16.5% compared to 8.2% of whites. This was the Department of State Health Services recent estimates at 2010, but actually I checked CDC last night and it is now 9.7 for whites. But even then, at 16.5% for African Americans, we can see that it's significantly higher. And their mortality rates, age-adjusted mortality rates per 100,000 is 36.8 as compared to 16.5 for whites. So we know that they are have higher rates of death. What I want to do is when we hear numbers, we don't seem to personalize or really understand or appreciate what those numbers, other than just more African Americans are dying of diabetes. But we have to put it in the context, the cultural context. Why are they dying at higher rates of death than whites? Is it their access to care? Are they getting diagnosed early? Are they getting the treatment they need? So when we look at death, we're really looking at a bigger problem. There again, a bigger problem. Why are the rates higher? How can we impact that in what we do in terms of diabetes self-management education, which is a large emphasis that is in nutrition? Because obviously the mortality rates come from complications that come from poorly managed diabetes. So when we look at Hispanic Latinos, and I say Hispanics, this, the data calls them Hispanics. I use it Hispanic Latinos interchangeably. 11% compared to whites. Again, that number has been. I'm going to use CDC's numbers of 9.7, so it's a little higher with CDC rates. So again, they're higher, and then similarly to African Americans, their death rates are higher too. So again, we look at these two groups and we're seeing higher death rates and higher prevalence of diabetes. Some other things to tease out in statistics is also hospitalization. We are looking at African Americans, and particularly that one group, the hospitalizations due to diabetes are extremely high. And as you can see, they're a little over double than whites. So when we talk about death rates, we're thinking hospitalization, poorly managed diabetes. There we're starting to see a little clearer picture of some issues that could potentially help us identify solutions. And then lastly, I wanted to bring up obesity. I know that obesity is a big cause of, a contributor to a lot of chronic diseases, and it is particularly impacts the development of type 2 diabetes. And as we can see here, African Americans and Hispanics both have significantly higher rates of obesity, which predisposes them for the development of diabetes, if not pre-diabetes, which is now we hear a lot about. And so, weight loss is very critical to reducing your risk for the development of diabetes. So when we see that, we see not just that they have more cases of diabetes, more are dying from diabetes, but they have a major risk factor for developing diabetes. So that's one area of concern that we can look for solutions to before they develop type 2 diabetes. I thought when I was checking statistics, I was also thinking about looking at what they were, Hispanics and taking diabetes education. That is the most peculiar sound. And I found that this was kind of interesting, is that they have lower rates compared to whites in taking a diabetes management class or any kind of diabetes education. So we're missing them in the class in getting the diabetes education that they need. I wanted to find the same statistics for African Americans, but in this particular study, which is the Behavioral Risk Factor Surveillance Survey, they have the interactive survey that you can go and pull these different statistics. The numbers were so low that they could not analyze it for African Americans. But I would gather that they might also have lower rates of taking a diabetes education class or any kind of diabetes education compared to whites. So that also gives you some context to understand some potential issues that affect Hispanic Latinos. So as I was thinking about the two programs, Si Yo Puedo, as well as Wisdom Power Control, for both programs, when we developed them, we had a pilot program to test them in Texas. Both of these projects were funded by the USDA in a grant. Now, a year ago, I did a pilot for Wisdom Power Control, and then 4 years ago, I tested Si Yo Puedo. So both of those programs have been tested and shown to be effective, and I'll show some data on that in a little bit. But as we were looking to identify potential sites where we can have our classes tested, we identified several counties in South Texas. And right now, if you look at the Texas rates, they're not, they're comparable, very close, so they're not as high. But you could see Hidalgo County, which is down in the very southern tip of Texas, is running a lot higher than the Texas rates. Now, Star and Webb are pretty comparable to the Texas rates as well, and Cameron County is a little lower, which I was surprised to see that. And I'm not too sure why that is, because I thought it would be higher. But one of the reasons, even though the prevalence is comparable to the Texas rates, one of the reasons why we targeted those areas is the number of Hispanics in those counties. I'm going to kind of just show you tell you a little bit about how startling, well, not startling, but it's to be expected because it's a border community. But to put you in context, remember we said that 40-some of Texas state population are whites. Well, in Starr County, there's 95% Hispanics. In Hidalgo, there's 90%, and then 96% are Hispanic. So it's just like everybody there are Hispanic. So if you see that the majority, almost the majority of those counties are Hispanic, then you can see the impact of diabetes in those communities, even though compared to the state rate, it's pretty comparable. We're also looking at a large segment of that population are Hispanic. And then, of course, when we look at East Texas, we find a larger concentration of African Americans in East Texas as well as in urban areas. But this is one particular slide that I do want to bring this to your attention, because look at the rates of diabetes. We always hear Hispanics, and they do have a problem. But if 12% of the state are African Americans, that's a small segment. But even the small segment are significantly impacted by diabetes. I mean, very high rates. So we concentrated our last year's pilot in those areas as our target areas to implement the program. And so this helped us kind of identify where there is a greatest need for both Wisdom Power Control and Si Yo Puedo, that we can have the greatest reach to address the problem. And we focused in those counties with the highest rates of African Americans as well as Hispanics. Now, I didn't tell you the rates of population rates, But just to tell you, say for instance, in Jefferson County, it's 33% African American. So, and the state is 12. All of these counties have higher proportion of African Americans. Cass County up in the corner on the Louisiana border is 17%, a little higher. Harrison is 22%. So all of these counties are heavily populated by African Americans. So we saw that as a great need. We saw that there was a lot of potential for wisdom power control in these areas of reach. Yes.
So as far as East Texas and diabetes go, those are very small counties. Why didn't you use maybe Tarrant County, which is the Houston area, or the Dallas County, which is a very large area?
Good question. Because the grant was for rural areas, so we focused on rural areas. But we are beginning our reach in Houston. We've got some collaborations there in Houston and Dallas. So it's not that we're limiting the program to there, but we were just doing a small scale study in those areas with the idea that after the pilot year, it would be refined and ready for statewide dissemination. So we would be. And you are right. It is very high, and particularly in Houston, in the Houston area. So the big question now is, how can we improve diabetes outcomes for minorities? And that's where we're going to look at research to real world. And the American Diabetes Association has their standards of care. And in there, they've outlined what are culturally competent care in diabetes treatment and management. And some of the key points that they outlined in their standards were to get community input, to improve access to care. And by access, it's not just having the services just available in their community that they can go to the classes. It's addressing social economic barriers, such as being uninsured, not having, a healthcare provider, a regular healthcare home, and those kind of services. But also access to care is who's going to deliver it? Do we have the manpower to meet that need? Because interestingly enough, as much as we see the need, we can do, the services are available in the clinics, certainly. But to have greater reach, we have to go out to the community. And for a program to be culturally competent, it is best to serve them where they are, in their communities. But who's going to deliver those programs? So those are all access issues. Ensure instructor competency. Who are we going to have to deliver these programs? Are they competent to deliver them if we're not doing it in a clinical setting? And then evidence-based curriculums. We can provide any kind of information that we could call diabetes education, but is it based on science? Does it work? We have to know if those programs are tested. And then lastly, to provide individualized care. What I've been focusing a lot is in group-based education, but as much as we give them a class that's for a group, it is still individualized in how we approach that group education. And I'll talk about that in a little bit when I talk about both of those programs. But to meet the needs of the individuals is very critical. So these are some of the things that are framed around culturally competent care. Now, the reach. So as we look at bringing it to the real world, are we reaching who we need to reach? And these are part of what we call community-based participatory research. How many has heard of CPR? Okay, one person, good. So a lot of times when we think about research, we think about, okay, we're going to test this program. We're going to show them, who's them, the community, that it works. But before we can even be that presumptuous, we need to get community buy-in. we need to get their support. We need to leverage their resources. So we need to get their buy-in. To reach, we need to conduct focus groups to hear, is there a need? What do you want in terms of diabetes education? What will meet your needs the best? We're going to involve in community coalitions. We need to get our community members activated so that there's representation from that community. We need to identify their specific needs to inform the development of a program. And then once we gather all that, get that support, then we can take what we know works and best practices, and then frame a curriculum in a culturally competent manner. So this is what reach is. Reach, when we think of reach, we think more physical, like I'm going to reach them, I'm going to target the class, but the reach means that it is really engaging that community to be part of that process of bringing diabetes education. They can address the big need. So relevance. As we take to that next step of understanding reach and engaging our community in a meaningful, culturally meaningful manner, then we're going to look at creating the curriculum. Some of the methodology that helps you understand how to develop a curriculum that is culturally relevant is to use mixed methods. You know, you could do needs assessments as part of the program development process. And I know that nutrition might touch a little bit on that, but part of program development is supported by data. And that data tells you, okay, this is quantifying what are their needs so that I could develop a program that really is going to be effective for that unique population, that minority group. And that could be done with both, like I said before, focus groups, as well as just surveys to find out where we can address some of their needs. Then the next thing is to select behavior change theories. In developing both the CFWEDO that was translated for wisdom, power, control, when I started that 7 years ago, I didn't really have any funding to support qualitative research or quantitative, so I looked at literature to see the need, to see what was out there in terms of any diabetes education programs that are targeted for Hispanic Latinos, but specifically the subgroup of Mexican Americans, because that's who we reach in Texas, and that's the largest subgroup of Hispanic Latinos. And as we know, Hispanic Latinos are not homogenous. You've got Puerto Ricanos, you've got Cubans, you know, so what has been out there and what has been done. So I use literature to inform the development of the curriculum. And then what I did is the next step is, okay, so we're trying to change behaviors. I know many of you, because you do nutrition education, I know many of you wonder, why do those people put the food in their mouth? You know, don't they know that greasy hamburger is no good? But, you know, why is it? How do we change behavior? So I explored literature even further to see what are theories in behavior change that can be effective in motivating behavior change. And so in the development of CFWEDO, I use the social cognitive theory that among some of its constructs are the self-efficacy, so if you build their confidence, empowerment. Role modeling is another construct of social cognitive, so you've got people role modeling positive behaviors are more likely to make the change. We've got social support that is another element of that. So I looked at all the different things of that theoretical framework and made it real. So I knew, okay, goal setting and say, for instance, building their self-confidence. How do we take what we know is a theory that says it's going to change behavior and apply it to the real world? And I'll just keep you thinking about that. And I'll tell you how we took the social cognitive and the self-regulation theory is used a lot in nursing, and I use that because what self-regulation possesses is that if people monitor their behaviors, set goals, they're more likely to change behaviors. So if you can imagine building a house and you have the foundation that the house sits on or stands on. That's what the theory did for Silla Puedo. And that's what we used to apply it into some practical approaches in the development of the curriculum. And then, of course, adapt those strategies as I described. So, translating evidence-based practices. Translating is now a big word. I don't know if you've heard the word a lot about implementation science, translational science, and so forth. Well, I want to kind of give you a kind of interesting, I think, real-world application in translational research. I will describe the curriculum in a little bit, but this is a really good place to discuss translating a program or evidence that works. And what we're going to do is we're going to take Silla Puedo, because we had shown through a pilot study that it worked. And how do I know it worked? Well, they improved in their self-confidence, they improved in their diabetes self-care behaviors, they improved in their A1C, which is a clinical measure of their blood glucose levels over a 3-month period, and there was a reduction. A modest reduction, but there was still a reduction that did have a positive impact, because having your A1C below 7% means that you're at a lower risk for complications. You have a lower risk for complications, you're less likely to have problems with diabetes, or reduce your risk for problems that can lead to poorly managed diabetes, that could lead to probably like kidney failure and the like, and death. So you can see how it all connects to each other. So we knew that Silla Puedo worked, and I'm going to kind of show you how you translate this evidence-based practice. So we started out with Silla Puedo, but we knew the problem was even greater with African Americans. So I wanted to take the evidence-based practice, and in this instance, it's Silla Puedo, and how I could see if that could work for African Americans. So I got community input, and I'll tell you how that worked. So I went and did focus groups, and I did a focus group in Jefferson County, which is 33% African American, extremely high rate of diabetes there. And I also did it in Houston. So I did two focus groups to see what are their needs. And what I was really looking for is, A, do they want a diabetes education program? And B, if they do, what do they want in the diabetes education program? And then I assessed their needs to design the program. Now, I was going at it thinking that I might have to create a whole new program, that what was working for Hispanic Latinos might look completely different for African Americans. But I didn't know that. And so I kind of had to frame the focus group with some of the things to describe, like if we did this, would this work for you? And one example is in Silla Puedo, we have video novellas. And the video novellas are soap operas. And we play out every week this story of these two central characters who are talking about some aspect of managing their diabetes and how they address that problem. So it's a little bit of that role modeling construct that goes with social cognitive. But I thought, well, what if they don't like, novellas is not relevant to them, and then I have to think of something that could kind of fit that piece. So I didn't know what could work for Silla, whether it could work for African Americans. And then testing, and then finalizing, and then you disseminate it. You just take that program, you adapt it in the way that works best for that population. That's what we call translation, and then you disseminate it. So I'm going to talk just briefly about how I translated Silla Puedo in a culturally relevant and meaningful manner for African Americans. I'm kind of wondering how many of you, I kind of know things, have ever heard of the Pan3 Model by Collins and Ramula. I didn't expect that, but anyway, he was a popular theorist at my doctoral school at Texas Women's University. Everything was Pan3. But so this theory is talking about how you take what the values of culture to frame the development of a curriculum or a program. Okay. Collins Arambua used the Pan3 model in developing programs for HIV in Africa. He's from Penn State, but he's used that theory. And that theory has played out to be very valuable in applying this model to help develop programs, health promotion programs for ethnic, racial minority groups. So so you see the acronym Pan3. So there's 3 concentric circles. There's 3 dimensions of this Pan3 model. The first is to look at the cultural identity of that community, of that individual. Who's that? So you look at the person, the individual. What is their cultural identity? What is relevant to them as an individual about their culture? Then you look at their extended family. What is it about their family values? What is it about their the family norms? How they eat, how they, whatever is unique to that family structure, because the family is very critical to understanding culture. And then you look at the neighborhood. They're like in Africa, the villages, the neighborhoods, the influence of their neighborhood, of their community, of their social circle. Then you look at the relationships and expectations, and this is all relevant to health. What are their perceptions about health? Do they feel like, are their perceptions could be affected by, say, for instance, with Hispanic Latinos, they have this fatalism value that it's all in God's hands and that whatever happens, there's nothing that I can do to control it. That's a cultural value. Or, it's all, my family is the one that's going to get me through this. It's the family, the value that they hold that influences their perceptions about health that are unique to that culture. Then you look at enablers. And enablers is more, what is it in their social environment that either helps or hinders their health behaviors? It could be their work environment, it could be their church, it could be a number of things that are in that culture that enable both positively and negatively the health behaviors. And then the nurtures are those more intimate social circle like family and friends, co-workers that could either positively or negatively influence those health behaviors. And then and the last thing is cultural empowerment. And that is looking at the actual cultural existence. I mean, what is about their culture? So it could be those positive things that exist within their culture that could be, say, for instance, the feeling of, one example that I think of positive is family values that you find very strongly both in African Americans and Latinos, as far as how important they are to making them feel that I'm going to do better to manage my diabetes because my family is important to me. Or existential is looking at some unique aspects of the culture. In the Hispanic culture, they have curanderos, especially in South Texas. Those are faith healers. But similarly, in the Black culture, we found a lot in the Black churches, these faith healers that laid hands on people, and they believe in that, and they believe that they will be healed. So those are existential values that affect health. And then lastly, negative factors that are part of their culture that could adversely impact their health behaviors. Like, say, for instance, they might have some kind of herbal remedy that they take, but it might not be the best thing for them in managing their diabetes. So if you look at the cultural conceptual framework, you look at the individual, the person, the neighborhood, then you look at their perceptions and their expectations. So that's attitudes and beliefs. And then you actually look at those factors that are specific to the culture themselves. So you're probably thinking, okay, what does all this mean? Well, I took a focus group, and when I did that focus group, I used the focus group data to help me flesh out meaning of what they of their responses using the Pan3 model. And then this would lead, just to let you know, this would lead to developing the program. So in this model, what you do is you take the cultural identity, which is the positive, existential, and negative factors, and then you take the perceptions of the culture, and you look at those, and you look at the intersection, how they cross each other. Now, the last thing is a cultural identity, but that domain doesn't come into picture until after you kind of see the intersection of these values. So some of the positive things that they had in their focus group feedback was that they need to be informed, that they have a desire for education, that they really value the importance of education, that is important to the African Americans that we interviewed. Some of the existential perceptions that they had was that view of fatalism, like there's nothing I can do about it. The good Lord gave me this diabetes. My family's all died from diabetes. There's nothing I can do about diabetes. And these were some of the feedbacks that we got. And the negative is that perceptions is that they said that what they're getting is poor education, that they just don't have the services. They have fear of complications, and denial was a big factor. Okay. When we looked at enablers, we looked at their church as positive enablers, but negative enablers were the healthcare system. Several of them reported being treated very disrespectfully by their physicians. One was very overweight. He had gone to the emergency room. His blood glucose levels were over 400, sky high, and the doctor just basically said, well, you should be losing weight. That's all, you know. But existentialism, we looked at religion and their beliefs and their faith. They put a lot of emphasis in that in helping them get through their diabetes. And the nurturers were their family and friends, but the negative nurturers that we found were coworkers who they said were the food police, as they said, because every time they wanted to have a Coke, there was somebody there getting on their case about wanting it. And they said if they were informed, they would know that my blood sugar was going low. So how do we take what we found in our focus groups and applying the Pan3 model to plan a program for them? Well, what we ended up finding out is that they wanted a family-focused program. They wanted a program that was focusing on the spiritual, that was in their churches. They wanted a program that they can also, like I said, not just involve the family, but that could give education to the family because they felt the family members needed to be more informed. There were a couple of other things that we also looked at. And remember the cultural identity and the looking at the neighborhoods and so forth. Well, one of the things that we did find out is that they felt that programs that were offered in the church would be the best entry point to give classes to them in the community. And so we really kind of summed it up was that they wanted a program that was family focused and spiritual. Now, when we took the City of Weather program, we asked them a little bit about the novellas. We asked them, oh, well, we do this, you know, we gave them some examples of some of the activities that we did in City of Weather. And they all kind of affirmed, yeah, we would really, you know, that would be something that we would find useful. So we found that we didn't have to do many changes. As a matter of fact, if you look at City of Weather and Wisdom Power Control, they're almost identical. The one thing that I thought was going to be a sticking point was the novellas. Because I thought, well, how would they find this relevant? And they actually said, well, we want our own videos. So we developed video novellas for them. And we made it appropriate with the same kind of characters that are representative of their community. And so and that's the translation process. That's how I used a culturally relevant theory to inform the development or the translation of best practice City of Weather to develop wisdom power control. So real world results. Just the bottom line is as you develop this curriculum and you find out what is meaningful to them, what curriculum will work for them, then the bottom line is you want to see results. You want to measure outcomes. You want to know if it works. So you need to be able to have in place some measurements of seeing the success of that curriculum. And for Selfregulation and Wisdom Power Control, some of our main measures are knowledge, although knowledge does not translate into behavior change. And we want to see also some changes in behavior by learning skills. So we teach them how to use a meter, we use them to help them learn about meal planning, and then also reducing their A1C. And that's all contingent on funding, to pay for those A1Cs, but we were able to do it in our pilot. So big need, reaching African Americans and Hispanics. And so what do? So here's the Selfregulation program that we've talked about, and that is now fully implemented statewide. We have a national presence also. I'm very excited because we've got Purdue Extension implementing this program on a very small scale. They have a lot of migrant Hispanics there, but they are still having some challenges in getting trust and getting people to come to the classes there. We have a program in Albuquerque, New Mexico, and then just last week I was contacted by Yale University, and they're partnering with me to implement Selfregulation in the interior of Mexico. And they're going for an R21, and if it gets funded, we'll be able to test it in Mexico. Wisdom Power Control is now the program that has been translated that I talked about. And it is being rolled out. I'm still looking to get a little bit more traction in finding more areas to deliver this program. There is a little challenge because the pilot had some challenges in getting more community buy-in. And we'll talk about that in a little bit. So what does the program look like? It's 7 weeks. It's a culturally relevant intervention, meaning that, say, for instance, food cards that we use in the program, the food cards that we have for Hispanic Latinos are foods that are their preferred foods as compared to the foods that are with African Americans. The food cards are unique to each group. We have an empowerment-based program. It is all based on, yes, I can do it. We have this power phrase that we use in both programs. And the power phrase is what's used to kind of motivate them and charge them up. So the Selfregulation means, yes, I can. So every week we have a power phrase for each week. So say, for instance, Selfregulation, the first week is Selfregulation controlar mi diabetes. And they say it out loud and they do it like a cheer. And I was surprised something as cheesy as this really was motivating. And when we did the focus groups, they said, well, we want, power phrase. And they said, that song, I Got the Power? Well, that's what theirs is. I've got the power to manage my diabetes or to manage my stress. And so every week you have a unique power phrase that supports that week's topic. It's guided by the social and cognitive and self-regulation theories that I alluded to or talked to earlier. It builds skills and knowledge such as meal planning, food labeling. We have a lot of that, and it is based on, it's a process-oriented program. You build from 1 week to the next. So we start with simple carbs, then we go, and we help them explain, well, what is, for example, here we have these food cards, and they start with just broccoli. And, just tell me basically, what is a carb? And since we do food sorting, high, low carbs, then then the third week we add proteins and fats, proteínas and grasa, because that's part of, the macronutrients. And so we got all of that. And so they do the food sorting. And we help them understand that you've got the plain potato, and then go a week later, and then we call it a combination food. Like in the Mexican food, you have the enchilada, which is the tortilla, and the meat and everything. So we build their knowledge every week. Everything is sequential. And so that we just don't throw it all at them, so they can understand how everything interconnects. But the bottom line is we're trying to teach them the relationship of carbohydrates, what they eat, to their blood glucose levels. And we start with, by week 2, from teaching them how to test, and then having them have 1 day where they test all day after their meals and when they get up, and seeing how their blood glucose readings are, if they're within a range. And then they start saying, oh, I see, I had 4 tortillas, and my blood glucose levels 2 hours was really high. Now I know why. And it's family focused. Both programs, family members come to the program. They're asked to be part of it. It's a great program to engage family members, and especially to prevent diabetes for that group of people. Aims earned increased knowledge, self-care, self-confidence, and quality of life for both programs. Just to demographics, all I'm going to say is that we target mostly women. Mostly women come over the age of 50 for the Hispanic group. This is last year's or 2 years data. And we find that at least with that group, as well as the African Americans, people have had diabetes more than a year. These people are really hungry to get education. What they're getting is just not enough. So, and then in the demographics, a little older age group, still we're seeing more women than men coming to the classes. I'm not sure what that is, but I do think that typically women are the caregivers, so you'll see them coming more to the classes. Yeah. Oh.
Yes, I was wondering if there was a particular reason why you used the social theory and the self-regulation theory compared to the Pan3 Theory or the other.
The social theories seem to have worked well for what we were looking for, especially the self-efficacy, the role modeling, building the goal setting. So when I look at that, and a lot of the other literature also supported that in showing that that was like when I looked at some diabetes education programs that were for that group, they were typically the social cognitive theory. So it seemed to be working well. Yeah, and I know about planned behavior and some of those. But some of those concepts like self-efficacy, they're used a lot of those theories too. And there's also the stages of change. Are they ready? Usually get people who are ready, the ones that come to the class. I'm sorry, I overlooked that. I don't want to go through all of these, but all I want to show here for Sigue Puedo in our 2012 data, that there was a big improvement in knowledge as well as self-confidence in all of our measures. We added another scale on this distress score, and the reason why is that we know depression is very high with people with chronic disease. So we have a 6-item scale that is now looking at depression. We call it a psychological scale because there's a negative stigma to calling it a depression or a distress scale. And we're seeing that their affect is being positively influenced by it. And we have, with the Hispanic, we have a moderately, I guess what I would say is that they're not very acculturated group that we have coming to our classes. So in all of our measures, we're continuing to see success in the improvements in our primary outcome measures. In our pilot, the same with wisdom, power, control, again, improvements in all of the measures as well. So we're seeing that it's working, and we're seeing that part of the reason why we believe it's working is the relevance that that program has for those groups. I'm kind of running a little faster, or if I feel like talking fast, I realize that I could talk forever and I could probably run late, so I want to try to make sure I cover everything. So the big difference is changes with impact. And one of the things that we have learned through these pilot programs is that we are mobilizing communities to form partnerships and to share resources. That is where Sigue Puedo and Wisdom Power Control is going in terms of dissemination and diffusion. Is that it is a program by development, and I never said this, but biggest thing, I'm with AgriLife Extension Service. I just totally missed that. Sorry, Jenna. But anyway, I don't know, are y'all familiar with AgriLife Extension Service? Some of y'all, I have had some students here on campus that didn't know we existed. So we're like over there. But the mission of AgriLife Extension is to bring science-based education to our statewide constituents. So this program is to serve our statewide constituents. And we're rolling out Sigue Puedo. It is a recommended program by Texas Diabetes Council. Even the CDC is recommending it And we have a lot of community partners like faith-based organizations like the Methodist Healthcare Ministries, federally qualified health care centers. We are working with agents to deliver the program as well to identify community partners. The program for both of these that I didn't mention is designed to be implemented by healthcare professionals. So that means RD, RN teaching team. The challenge we're having is a shortage of RNs and RDs. And then the shortage of RNs and RDs who can give of their time to do this program because it is a 7-week program. So our next steps with CFWEDO that we want to eventually do with this power is to look at community health workers as a new method of delivery. So I submitted an NIH grant to see about testing CFWEDO with CHWs because you just don't say, oh, we're going to have so-and-so deliver it as compared to the way the program has been designed. How many are familiar with the term fidelity, program fidelity? You just don't like have somebody deliver it and say it's all well and good and they can deliver it. Programs that are evidence-based have to be delivered with fidelity, meaning with the purity of the program as it's designed. So it's been shown to be effective with healthcare professionals, but we can't make that same assumption with community health workers. So community health workers is a logical profession because they're paraprofessionals. Texas is the only state in the union that has a state law that requires a certification process for CHWs. So they're highly trained. They have 160 hours of this training for their certification and every 2-year CEUs that they have to maintain. So we are getting a high quality educator who is going to increase our relevance because CHWs are typically individuals, lay health workers from those communities. And then transforming communities. One of the big things about both programs is that this is promoting health equity. We're addressing a need in the state, a need in the nation, because I'm seeing this program really go statewide. And we're seeing improvements in health outcomes and among underserved minority groups. And when you see these improvements, you're transforming the communities. But we're also changing lives. We're seeing people with better control of diabetes, reducing their risk for complications, improving their quality of life, empowering them, increasing confidence, and positive impact on families. So lives are being changed. I wanted to show you this slide really quickly, a couple of slides. Some feedback from people in the class. This person said how it helped with her accountability and starting, that now she's starting to test and eat and seeing how it affects me. These are the things that we focused on that were our core values of these curriculum, and they're happening. I mean, it's so way cool. I can't tell you how cool it is when you develop a program and you have this vision that you want to see happen, and you're hoping that it happens by doing everything right, like testing theory, making sure it works, getting the needs from the community identified, and then really putting it into an actual program that works. This is it. This is the program. It's a turnkey approach that people who meet our criteria can deliver it. But then the faces are what speaks volumes for the program and the support that they get on both communities. African Americans and Hispanic Latinos both said, we want support. And I have to share this precious lady in Harrison. She's in Marshall, Texas. And see that little piece of cake there? Okay. She went to a social affair, she was saying there, and she got a little piece of cake, and the county agent was there, so she didn't want to eat it all, so she put it in a little bag. And she said, I only just ate a little bit, and she brought it to class, and she said, I've had it the whole week, and I only had a little bite, but I'm having more control. That's just like, those are just wonderful stories that we get from our participants. And then just the confidence that they have to make behavior. I mean, even going from 6 to 7. I mean, that doesn't sound like a big change, but it's improving their confidence. And what that is we have a confidence scale where we set goals and we say them on a scale of 1 to 10. How confident are you to do that behavior? And people just sit on a certain confidence level, but just to inch up was a big deal. Now, I wanted to show you one video. Do we have time? We have time to show one video. Oh, we have time?
There's a class after.
Okay, so we don't. But I wanted to show you a video novella, but it was really, I knew I was going to run out of time. I apologize. But I do have it on YouTube if y'all want to see it. You guys email me. Is there any quick questions or anything that I can address? Yes.
So the ones that dissipated the information were actually with the community, was it community health workers?
No, we still have not had community health workers deliver the testing with them. Right now, RMRDs are the ones that, yeah. And I just have some lesson learned. We're running out of time, but just to say that some of the challenges were just getting community trust with our African American population, and that the Black churches were instrumental. And lessons learned with Hispanic Latinos was just the desperate need that we saw in the colonias, and that community stakeholders was critical for recruiting our participants. Thank you very much. I know I covered a lot. There's a class coming in after here. If you want to grab me afterwards at the lunch, I'll be glad to answer any of your questions.
Make sure you sign the class.